For the second presentation today, we have one of the most elegant speakers who will feed us in his easy and smooth way and sure with highly effective tools of knowledge. Dr. Mohamed Raslan will give us a lecture about the era of interventional radiology and its role in management of PE. Dr. Raslan is full-time consultant interventional radiologist in King Abdullah Medical City, Makkah, KSA, and currently he is in locum interventional radiology consultant in International Medical Center in Jeddah, KSA. Dr. Raslan was graduated from Faculty of Medicine, Tanta University, and got fellowship of Royal College of Radiologists, London, UK. Also, he held European Board of Interventional Radiology, as well as Vascular Interventional Radiology Fellowship in Singapore General Hospital. Dr. Raslan, the floor is yours.
Thank you, Dr. Sharif, for your nice presentation. And actually, I'm grateful for Dr. Saad Mahdi and Professor Adil Hussein for inviting me. It's a great pleasure to be with you tonight. I will try to shed some light on how percutaneous intervention can contribute to managing cases of acute pulmonary embolism. I have no disclosures. Actually, it's hard to cover all the aspects relevant to this topic in one presentation. So I try to focus on certain points and skip others, which were covered by the previous presenters last week and today. We will go through types of catheter-directed therapies. For BE, we will go for rationale of catheter-directed therapies, indications, contraindications, devices available, the evidence and limitation for each, and challenges for catheter-directed therapies, and finally, the summary. As we all know, acute BE is a common life-threatening condition that represents a severe manifestation along the spectrum of venous thromboembolic disease. And BE is the third leading cause of cardiovascular mortality after myocardial infarction and stroke. The two main bodies concerned with the diagnosis and management of pulmonary embolism are the American Heart Association and the European Society of Cardiology. Therefore, their guidelines are the ones mostly adopted in this aspect. So for simplicity, this slide shows the main sources of this presentation, which again is the European Society of Cardiology guidelines and the American Heart Association documents. According to the American Heart Association and the European Society of Cardiology, recent guidelines, acute pulmonary embolism currently classified into three categories: low risk, intermediate risk, and high risk. For the low risk class, which is the majority of the BE, with no hypotension or right heart strain, has less than 1% short-term mortality and can be successfully managed with the immediate start of therapeutic anticoagulation. For the intermediate risk BE, it is defined by the presence of right heart dysfunction in the setting of normal pressure, blood pressure. This represents as many as 25% of all cases of acute BE. The estimated mortality risk from intermediate risk BE is substantially higher than that associated with the other class category. Recent randomized controlled trial showed that 5.6% rate of clinical deterioration in the form of death or hemodynamic decompensation within 7 days, and 3% 30-day mortality rate with anticoagulation alone. This class is further divided by the European Society of Cardiology into intermediate high risk and intermediate low risk. The high risk BE is characterized by the presence of sustained systemic arterial hypotension defined by systolic blood pressure less than 90 millimeter mercury for at least 15 minutes, or requiring inotropic support. And these patients carry a mortality risk of 25 to 65%. As a result of the critical nature of this class, there is a current consensus that aggressive clot removal strategies primary reperfusion be considered, including systemic thrombolysis, catheter-directed therapy, and surgical embolectomy in selected patients, depending on the risk-benefit assessment, presence of contraindications, and available local expertise. Of course, not only aggressive clot removal is needed, but in most scenarios, emergent action needed to relieve the severe strain on the right ventricle. This can be a life-saving necessity. Okay, this is simply the classification. As you can see, the low is straightforward, everything is negative. For the high, everything is positive. The gray zone is the intermediate risk with its subclassification into high and low. As you can see here, it is the right ventricular dysfunction and the elevated cardiac troponin, which differentiate between these two classes or subclasses. Okay, you can see in this table both original and simplified version of the pulmonary embolism severity index. The original version, there are classes from 1 to 5, where in the simplified version, it has only 2 categories, either 0 points or 1 or more. For example, in the original version, you can see the cancer adds 30 points, while in the simplified one, it adds only 1 point. The cornerstone for treatment of pulmonary embolism is anticoagulation. However, adverse outcomes in patients with high risk and intermediate risk, despite of anticoagulation, have prompted many physicians to consider therapeutic escalation through either systemic thrombolysis, catheter-directed therapies, or surgical embolectomy. In patients with evidence of hemodynamic compromise, these techniques may be used in conjunction with invasive hemodynamic support devices, which, such as extracorporeal membranous oxygenation or isolated percutaneous right ventricular support, aiming to decrease the load from the right ventricle. Current use of this intervention is predicted on thrombus burden and location, which can be seen in CT pulmonary angiography, hemodynamics, overall patient condition, bleeding risk, availability, and operator institutional preference and expertise. Generally, endovascular therapy is expected to be more effective when the clot is in the proximal pulmonary arterial tree. Broadly speaking, percutaneous or catheter-directed intervention attempt to rapidly decrease the thrombus burden via pharmacomechanical means, a function usually called primary reperfusion. We have 2 types of catheter-directed therapies, mainly. First is the catheter-directed thrombolysis, which is the percutaneous intravascular infusion of thrombolytic agent through a catheter placed adjacent or within the clot burden in the pulmonary artery, pharmacological, with or without regional ultrasound assistance. Second, we have catheter-based embolectomy, which is the percutaneous intravascular transcatheter clot fragmentation and aspiration of the clot mechanically. In some cases, the two can be done concurrently or in series. The catheter-directed therapy has gained interest because of the limitations of both anticoagulation and systemic thrombolysis, and the complexity and the risk associated with open surgical embolectomy in some patients with high-risk PE. Although systemic thrombolysis is currently indicated in the treatment of acute high-risk PE, many patients have contraindication for these options. As you can see here, there are major contraindications and relative contraindication, and these definitely were discussed many times before. We will not repeat it. Even when patients with acute PE are pre-screened for absolute contraindication, the rate of major hemorrhage associated with systemic thrombolysis has been estimated at 9.2%, with a 1.5 risk of intracranial hemorrhage reported in meta-analysis of randomized controlled trials and observational studies. have shown that those bleeding risk may be higher among real-world population. Another point to consider is the time factor. When we have a patient and we go for systemic thrombolysis, this can be initiated in a shorter time than catheter-directed. However, the full dose generally takes 2 hours to deliver, and possible advantage of catheter-directed therapy could include the ability to use a lower thrombolytic drug dose, which can reach to 1/4 or half the dose, and obtain faster lysis as a result of targeted intrathrombus drug delivery and the addition of mechanical treatment, which can be combined pharmacomechanical. Among patients with intermediate risk BE, the initial goal is to reduce the mortality from BE without increasing the risk of treatment-related complication. Although recent meta-analysis of randomized trial demonstrated survival benefit with the use of systemic thrombolysis in this class, these data are also revealed much higher risk of major bleeding complications compared to anticoagulation alone. Therefore, this opened the door for hypothesis that delivering a lower overall thrombolytic agent via a catheter could decrease the risk of major bleeding complication by means of CDT. So, interestingly, previous study on the flow hemodynamic demonstrated that a systemically administered drug makes a little contact on obstructing embolus, and most of the drug flows away from the obstructing clot toward the open non-target vessel. This is called Venturi effect. If you can see this image and this right pulmonary artery blocked, the flow preferentially go to the open pulmonary arteries and avoid going to the blocked area. So this makes less exposure to this area and to these branches. Pharmacologic catheter-directed therapy override the Venturi effect because a soft, flexible catheter with multiple side holes is directly inserted under image guidance into the thrombosed target vessel to provide direct intraclot drug infusion, which means less amount of drug needed and less complications. Therefore, it offers a better efficacy than anticoagulation alone and a higher safety than systemic thrombolysis. So this summarizes the situation. As we can see, the anticoagulation is very important and safe. However, it's not sufficient in all cases. For this systemic thrombolysis, it's slightly more aggressive than the anticoagulation. And for the cardiac surgery, it has a higher mortality. Here, there is a chance for the catheter-directed therapy to show that it is safer and more efficient. The advantage of the catheter-directed therapy, again, is direct action on the clot, use of less dose of thrombolytic, safer than systemic thrombolysis and usually faster, less invasive than the surgical embolectomy. However, nothing is free from this advantage. It is subject to availability. It requires a learning curve. Mostly it is expensive, still have complications, and less evidence. More studies are needed. This is the European Society of Cardiology guidelines and the evidence, and I'm sure this was seen before many times in the previous lectures. And here also the level of evidence for the catheter-directed therapy. So what are the available devices? Okay, these are the list of devices available, okay? Some examples of the most commonly used devices for catheter-directed therapy for BE. The first 3 devices in this table are based on lysis of the thrombus by infusion of TBA. And the last 5 are pure mechanical. Last 5 here are pure mechanical. And the Bashir catheter is the pharmacomechanical one. You can see here the Bashir catheter. This combines the pharmacological and the mechanical together. As you can notice, the difference in size between the two groups here in the infusion, you can find it's 5 and 4 French, while in the mechanical, it's usually a larger lumen, like 20 French, 26 French. So just to get an idea, how is the difference between both? We have pharmacological and we have mechanical. Pharmacological usually smaller in caliber, and mechanical is larger. And as you can expect, Bashir is somehow between. Among these devices, only 3 had the FDA clearance for the use in pulmonary embolism. Namely, we have EcoSonic, we have FlowTriever, and we have Indigo system. We will go through them one by one. Important to say that there is a device called AngioJet. This device has a clearance for peripheral thrombectomy. However, it got black box warning against the use in pulmonary artery from the FDA. This means it showed unjustified risk, so it was black boxed from FDA. And this AngioVac device, which is circled by blue, this is also not used for pulmonary thrombosis of the pulmonary artery. However, it is useful in IVC thrombus, and it's useful in clot in transit, which is a very unique and specific entity of the thrombus. Again, we have these 3 devices cleared from the FDA. First, it was EcoSonic in 2014, then FlowTriever in 2018, and finally, in 2020, we have the Indigo aspiration system. In the coming slide, more details about these devices will be shown. So, for the catheter-directed lysis, this refers to administration of thrombolytic drug directly into the pulmonary artery circulation, or even to within the clot through a multi-site hole infusion catheter. This helps to overcome the Venturi effect mentioned before, okay, faced in the case of systemic thrombolysis. Most publications of catheter-directed lysis have reported a dose of approximately 1/4 that usually given systemically. For instance, 20 to 24 milligram alteplase, although the optimal dosing strategy is still being actively investigated. 2 commonly used catheter-directed lysis catheters, simple catheters, which are Unifuse and Mcnamara. Both carries an indication from FDA for infusion of thrombolytic into the peripheral vasculature without a specific indication for pulmonary embolism. Operators typically use 4 and 5 French catheters with infusion length ranging from 5 to 10 centimeters, depending on thrombus burden. So they are used in the pulmonary vasculature as an off-label use. This is the Unifuse. This catheter typically placed over a regular wire with the clot within the clot. This helped by 2 radio-oblique markers in the catheter to show you where the infusion will be. So you can put the 2 markers exactly in the area where the clot is. And then you have an occluding wire, which is this one. It has a ball at its tip. When you put this occlusion wire, it occludes the distal end of the catheter so that when you start infusing, it creates a pressure which opens all the side holes to infuse uniformly from all openings. As you can see here, with a manual hand injection of the drug, once the pressure reaches a certain level, it opens the outlet slits which spray the drug evenly to the clot, because this tries to overcome a problem which usually faced when you have a simple infusion catheter, that the tip of the catheter usually takes the maximum flow and little is going through the side holes. But in this technique, with this occlusion wire, it directs all the spray into the openings uniformly. The second is Mcnamara Medtronic. This is a valve tip single lumen 4 and 5 French, designed to avoid the need of occluding wire. So the technology in this catheter is they make a valve at the end of the catheter, which open by wire, and when you inject, it's closed. So again, the infusion will be through the side holes, not at the end hole. So going now to the ECOS. As an alternative to the simple infusion catheter, this is an ultrasound-assisted thrombolysis with the Ecosonic endovascular system from ECOS Corporation. This was cleared from the FDA, as we said, in 2014. So it's a specialized catheter with 2 lumen. 1 lumen houses a filament with multiple ultrasound transducer that emits a high frequency, low energy ultrasound, whereas the other one allows local thrombolytic delivery through multiple ports along its length. Low energy ultrasound is claimed to facilitate the dissociation of fibrin strands, theoretically allowing more efficient thrombolysis at a lower dose by opening thrombus ultrastructure to thrombolytic binding. As you can see here, these are the ultrasound probes running through the catheter. So it's claimed that ECOS ultrasound helped to unwind and thins the fibrin strand to expose more drug receptor site. In other words, it opens thrombus ultrastructure to thrombolytic binding, as you can see here in the demonstration image. And this is how the latest model of ecosystem looks. You can see here that one device has 2 ports allowing to go for right and left pulmonary artery together. First, when we had the old version of this device, it used to come single device for single pulmonary artery, but now, so when we use to treat bilaterally, we have 2 devices put together and 2 catheters, each catheter going to 1 device. And you can imagine that how much space this would take in an ICU room, which may be full of other equipments. Okay. Again, this is the same appearance. So as with the simple catheter-directed lysis catheters, these catheters may be placed in 1 or both pulmonary arteries. These platforms allow gradual targeted infusion of thrombolytic, typically over 12 hours, although more recent data suggests that a little as 2 to 4 hours may have a comparable effectiveness. The biggest theoretical advantage of ultrasound-assisted therapy over the standard CDL is more effective penetration of the thrombolytic agent and shorter duration of time. So we have 3 studies performed for this ECOS. The first is Ultima study, which was done in 2013 over 59 patients. It's a prospective multi-center randomized trial comparing the safety and efficacy of unfractionated heparin alone, 80 international units per kg bolus and 18 international unit kg per hour, compared to the same protocol for unfractionated heparin with ECOS 10 mg RTBA if unilateral and 20 mg RTBA if bilateral, infused over 15 hours. So the conclusion of this Ultima that ECOS was superior to heparin alone in improving right ventricle, left ventricle ratio at 24 hours and 90 days, improving right ventricular systolic function at 24 hours and 90 days, with no increase in the risk of either major or minor bleed, recurrent venous thromboembolism, or death. The second study was the Seattle Study 2. It was done in 2015. It was conducted on 150 patients. It's a prospective multi-center single-arm study. This evaluated the safety and efficacy of ECOS in a massive or submassive BE, 1 milligram over 1 hour RTBA, 1 milligram per hour RTBA over 24 hours if unilateral, or 1 milligram per hour RTBA over 12 hours if bilateral. And the conclusion of this Seattle, low-dose ECOS thrombolysis improved right ventricular systolic function at 48 hours, improved the pulmonary hypertension at 48 hours, reduced the pulmonary clot burden with a low risk of major and minor bleed, recurrent venous thromboembolism, or death. The last one study was Optilase BE. It was done in 2018 on 101 patients. It's a prospective multi-center 4-arm study, and safety evaluated the safety and efficacy of ECOS with 4 different combinations of TBA doses and duration in acute submassive BE. 4 or 8 milligram over 2 hours, 4 or 8 milligram over 4 hours, 6 and 12 milligram over 6 hours, 12 and 24 milligrams over 6 hours. The conclusion of this study was lower doses and shorter infusion of ECOS thrombolysis for acute BE reduced RV-LV ratio in all arms at 48 hours, reduced the pulmonary clot burden at 48 hours, improved the exercise tolerance and the quality of life at 365 days for some patients, with a low risk of major and minor bleed, recurrent venous thromboembolism, or death. So there is no complete randomized comparison trial between the CDL and the ultrasound assisted in BE. A randomized trial of 2 modalities in the iliofemoral venous circulation did not show difference in early venographic or 1-year disease-specific quality of life measures, although the catheter-directed lysis, whether standard or ultrasound-assisted, offer theoretical benefit to the patient with BE, there are important limitations. The risk of hemorrhage complication inherent to the thrombolytic administration is not totally eliminated with these modalities. Means if we have a patient to treat with ECOS, we cannot expect that it's a free of hemorrhage. Okay, it's a reduced risk for hemorrhage, but it's not eliminated totally. This is the most important point to remember in this issue. And this is some ECOS catheter in position. This was the first device we got in our hospital. It gives actually good results in the selected patients we give. So catheter-directed lysis may be used in conjunction with a mechanical thrombus fragmentation, aspiration, or maceration to further promote thrombus disintegration by exposing a greater surface area of thrombus to endogenous or locally infused fibrinolytics. Complete thrombus removal is not the goal of this percutaneous method. Instead, downstaging from high risk to intermediate risk BE suffices. As you can see here, this is a large thrombus. When you macerate the thrombus, you expose more surface area so that the pharmacological means will find more surface to work on. So just to imagine the criteria for ideal mechanical thrombectomy device, we need it to be a strong suction, to have a strong suction, less traumatic, larger lumen, less bleeding, less blood loss, flexible with high torqueability, kink resistant, and it needs to be approved for the specific indication, which is BE, or you will need to go through IDE process. Not expensive and easy to use, faster to learn. Simply, you can see the comparison between small lumen catheters and large ones. The small lumen is less efficient in sucking the clots. However, it's relatively safer with less blood loss and less bleeding at the access site. For the larger lumen catheter, as we saw, some catheters were 26 French diameter. So it's more efficient in sucking the clots. However, it has a higher risk and it gives more blood loss and more bleeding at the access site. Sometimes it's recommended to use a closure device after you use the large volume or large bore catheter thrombectomy. So thrombus maceration, classically this was done using 3 catheters, modified big tail catheter, modified multi-purpose, and simply with balloon, which just smaller than the diameter of the pulmonary artery. You just open it to macerate the clots, and then you close it again, and then whatever you can aspirate the clots, or you can infuse some thrombolytic. These techniques may be helpful in hypotensive patients, this thrombus maceration, I mean, with totally occluded proximal BA branches, in which maceration can establish some forward flow and partially decompress the right ventricle until further treatment, for example, local thrombolysis take effect. However, distal embolization may inadvertently result in patient deterioration. Published evidence in these techniques is limited to case reports and series. The development of specific pulmonary embolectomy tools mostly will make these techniques obsolete, because you don't want to macerate the clots and just leave it to go distally and occlude more small and distal branches. You can just either infuse it or suck it with larger catheter. So second, we have areolytic thrombectomy with a device which we called before black labeled, black box warning from the FDA, which is angiojet. It has been used for BE thrombus removal with a variable success. However, because of the safety concern, angiojet device should not be used as the initial treatment with BE. The idea, technically, its use in the BE is similar to its use in the deep veins. It has a high-speed saline jet, travels backward from the tip of the catheter, creating a vacuum and thrombus fragmentation effect. This catheter can also be used for intra-procedural pulse delivery of low-dose thrombolytic agents like Alteplase 10 to 20 milligram. And of course, it's not recommended to start with cases of PE. So comparison on the large and small bore embolectomy, we have mechanical thrombectomy refers to actual extraction of thrombus from the pulmonary vasculature. Manual aspiration thrombectomy, a form of mechanical thrombectomy, can be performed by means of a large sheath or a straight guide catheter advanced directly into the thrombus, or by way of specialized catheter that are designed to facilitate greater vacuum effect. Examples of this is Bronto X large 14 French extraction catheter. This is an example of how companies make efforts trying to reach an ideal device. You can see here the smooth tip is less traumatic. The distal angle gives torqueability. You can push your catheter and steer it until you reach the desired area. And the braided shaft make it kink resistance, okay? And this notch here gives you a larger lumen for aspiration. And this ruler clamp decrease the blood loss, because whenever you suck the clots, it doesn't come out separately. It has to come out with a variable amount of blood. So to stop that, you have to have a stopper or this clamp to stop when you find blood is coming too much. So it's often challenging to remove a significant amount of thrombus with manual aspiration alone, because thrombi are frequently large and partially organized, making them hard to aspirate into comparably small size catheter or sheath. This opened the door for innovations to overcome this issue. But as we know, nothing is risk-free. You can see this device is the Aspirix, which is alternative to simple manual aspiration, which need a large volume, large lumen device. Electrical maceration and aspiration has been used. Example, in this Aspirix device, it has a electrically engined maceration device by rotating coils at the tip of the catheter to macerate the clots and create a vacuum. There are limited data on the effectiveness and the safety of this device, and it's not under current investigation for BE. Okay, for the large bore embolectomy, we have one of the FDA-approved devices, the FlowTriever. It's from Inari Medical. It is a large lumen device that approved for the mechanical removal of thrombus in the pulmonary artery. The device often used as a simple suction catheter with the advantage of its large lumen that facilitates removal of large burden of clot. You can see here simply passing the catheter with this large lumen next to the clot and start aspiration. It was approved from the FDA in 2018. And in this, in its simple way, it works like you introduce the wire, advance it through the clot, okay? And then the Triever 20 is advanced while the dilator in place until we reach the thrombus. And once we reach the thrombus, we remove the sheath, the dilator, and keep the sheath and start to create a vacuum with the syringe. It starts sucking the clots. Okay. Then the valve is closed and the syringe released and clots expelled out, inadvertently, of course, with some blood. Okay. If the clots are not easily aspirated by simple suction, the device has a unique alternative mechanism through deployment of 3 self-expanding nitinol discs that engage with the clot from within. The discs are then retracted back to the catheter with entrapped thrombus while the large bore guiding catheter is aspirated. In either case of simple suction or using the nitinol disc, the device is designed to remove thrombus without the use of adjunctive thrombolytics. You can see here, these are the nitinol mesh. You saw the catheter before. This is advanced inside the catheter. It will engage with the thrombus. As you can see, it comes in 4 different sizes to suit variable blood vessel diameter. The discs are first introduced over the wire while sheathed within the catheter. This is white catheter inside which the discs are still undeployed. Then you introduce it over the wire. Once you are in position and the thrombus is just at the nitinol discs, then you start unsheathing the nitinol discs. Okay. It is self-expanding. Once you unsheath it, it starts expanding, and then it engages the thrombus from within. Next step, you try retraction of these atraumatic discs. This will liberate the clot from the vessel wall and make it easier to aspirate. As you can see the arrows here, shows the aspiration through the large sheath, and this nitinol discs release the clot from the wall of the vessel and start moving toward the sheath while making aspiration on the sheath. And here is the catheter and the device with the nitinol, and here is the large bore sheath for aspiration. This is from the company site. And you can see how much clots coming out with this device. Unfortunately, it's not available in our country currently. So there is a single prospective multi-center single-arm study evaluated the safety and efficacy of the float reaver in acute intermediate risk BE, which is called FLAIR study. It was 1,106 patients in 2018. And the conclusion of this study was that mechanical thrombectomy with a float reaver system appears safe and effective in patients with acute intermediate risk BE. It significantly improved RV-LV ratio with a minimal major bleed. Potential advantage include immediate thrombus removal, absent of thrombolytic complication, and reduce the need of the post-procedure critical care. The second approved device is the mechanical embolectomy, is the Lightning 12. The Lightning 12 aspiration system from Indigo, Penumbra. It's a computer-aided mechanical aspiration catheter designed to engage the thrombus and extract it with a continuous vacuum pump. It was approved by FDA in 2020. The new technology in this version of the device, which is Lightning, is the thrombus detection algorithm by the dual pressure sensor in the tubes, which activate audiovisual cues to help engage and remove thrombus. This automatically controls a valve which changes from continuous aspiration while in thrombus to intermittent mode if within blood. Just to let you know, for the non-interventional radiologist, the main problem with the embolectomy that you are sucking the clots and inadvertently blood is coming. So all the companies are trying to make effort to decrease the loss of blood and increase the specificity of the suction to be only for the clots. And this is one of these devices that generates something like sensor that start to feel the pressure. Once the pressure reaches some point, means it's flowing blood, it's stopped, and make the valve on. And this make stopping for the aspiration and giving chance for the clots to move. Here, if the system becomes occluded with thrombus for more than 20 seconds, Lightning will notify the operator by flashing yellow light, which indicate that there might be a need to take the catheter out of the body and flush it out of the thrombus. Alternatively, the Indigo separator wire can be introduced to clear the lumen of the catheter. The separator is also helpful to macerate and detach large clots, blocking the tip of the catheter. And here is the canister after, of course, the canister usually is filled with blood and clots. And here are the appearance after suction. So the result of single arm extract DE trial, Indigo aspiration, it was done in 2019. 119 patients. It's a prospective multi-center single-arm study, evaluates the safety and efficacy of Indigo aspiration system in the acute BE. It was performed under investigational device exemption, IDE, from the FDA. The primary efficacy endpoint was significant reduction in RV-LV ratio at 48 hours. The primary safety endpoint was low major adverse events within 48 hours. And here, this is one of the first cases we have by Indigo, but this one was not the Lightning 12, because Lightning 12 is just recently launched and I don't know if it reached Saudi Arabia or not, but we still don't have it currently, maybe in the coming few weeks or months. And here you can see the separator coming out from the catheter. This separator has two functions. First, it clears the lumen if it's blocked by clots, which is not moving. Second, it macerates, it helps macerate the clots and free it from the wall of the pulmonary artery to make it easier for suction. Again, this is also the same patient. You can see here how the separator is moving, and it has angle, and this separator also is very soft, and they make it this way to decrease the risk of injuring the pulmonary artery while introducing the separator. Other devices we have, of course, as you can expect, all the companies are trying to compete in inventing an ideal device. This is an example of a device called Aspire Max mechanical thrombectomy. It was cleared by the FDA for the removal.
Dr.
Excuse me?
Unfortunately, we are running by the time.
Yeah, just 5 minutes, no more.
Okay.
Okay. This was cleared by the FDA for the removal of fresh thrombus and the emboli from the peripheral and coronary, but device has not been approved for the PE. So, what are the challenges we have for the catheter-directed therapy? We have challenges in the country that most of the countries are importing these devices. So this means a foreign currency to be paid and a burden to the economy, which is not always available in all countries. Then we have hospital challenges. First, you might not have a BIR team. You need to increase the awareness of all the levels in the hospital, starting from administration and other specialty about the guidelines and all the directives of BE. And definitely the budget of the hospital may not be enough to buy these relatively expensive devices. Then you have the departmental challenges, which is the availability of angio. Some hospitals, they don't have angio. Some hospitals, they have only one angio machine. And this angio machine may be busy with acute bleeding or, let's say, neuro case. So you need to have a protocol when to start with your case. In case if you have two emergencies, what you will do, which one you will give priority. And then challenging regarding the companies and devices. Unfortunately, sometimes the companies are biased to their device, and they are trying to push the studies to show that the device is the most, the best way to treat, and which may not be the case. And for the challenging in the healthcare workers, you need time, you need effort, you need to be dedicated to learn and to teach the people how to deal with these catheter-directed, because it has a learning curve and it needs dedication for that. So in summary, we have a solid evidence of efficacy and safety of the use of catheter-directed therapies in certain classes of acute PE, and most knowledge is derived from registries and pooled results from case series. Overall, procedural success rate defined as hemodynamic stabilization, correction of hypoxia, and survival to hospital discharge of catheter-directed therapies reported in these studies have reached 87%. However, the results may be subject to publication bias. We are lacking randomized controlled trials directly comparing catheter-directed with systemic thrombolytic therapy. Similarly, we have no available randomized controlled trials giving data on clinical efficacy outcomes, and there is no head-to-head randomized controlled trials for the current devices among each other. So a lot of effort still needed to be taken and the road is still open. Thank you so much.
Thank you very much, Dr. Raslan, for this magnificent lecture. Really, I enjoyed it. And if we have any questions, okay, I think no questions. I think you will agree with me, this still growing modality of management of acute pulmonary embolism, and we need more work to integrate this modality in the management of our patients to determine which patients will benefit from it. If we consider it as a first line of management. Dr. Raslan, I think could it be catheter-based technology or catheter-based therapy? Could it be the first line of management in certain cases? Do you recommend?
I believe that it's a part of the whole picture. As you know, and our audience also, the acute BE has to go in a certain pathway of diagnosing, and then in management according to the severity. If we are talking about low risk, this is totally away from our scope of talk. If we are talking about intermediate risk and the high risk, so you have priorities, you have to stabilize the patients. If in case you want to have a reperfusion, sometimes it's time is very critical, and even in many centers, when I go through the experience of other centers, they do the right ventricular strain release, and then they take a deep breath, and then they start the catheter-directed therapy. So sometimes, because going to catheter-directed therapy while the right ventricle has a severe strain in front of it, you may not have the luxury of time to open even with catheter-directed. So many people, they just, when they have this extreme severe scenario, they just go to decrease the strain over the right ventricle, and then they go like some people, they do ECMO, and then okay, they tell you go now and do whatever you want to take this pulmonary thrombus out. But priority is judged by the clinical situation of the patients. Like the best scenario is to have intermediate low risk. Not everyone is relaxed, but at least we are not in a hassle that we are losing the patient within minutes, as you, of course, know.
Yeah. Okay. Thank you, Dr. Raslan.